Hello, everybody. I am happy to bring a case to review with everybody who's present here. This is a case that we did in October 2024 in Tijuana, Mexico, through the Implant Accelerator. We have a program that does intensive soft tissue and implant training program, and this is a case that we did recently. I am Dr. Jin Kim. I am one of the co-directors of Implant Accelerator, the organization behind this training program. This case was done by Dr. Kayari Aljabi. He is a periodontist with 30 plus years of experience. He does practice in the Texas area and in Indiana, and he's done an amazing job with this case. So we'll share exactly what happened. This is a case that was presented. The patient was a middle-aged individual, lost a upper left first molar. And as you can see, the dentition is not very well aligned from this panoramic. But what is clearly noted here is that the sinus is quite pneumatized. The clinical evaluation revealed that there is mild to moderate horizontal and vertical loss of the ridge height, together with some severe pneumatization of the sinus. What is also noted here is that the soft tissue is a thick biotype. A thick biotype does have the huge advantage of being able to heal quite readily, and although we see signs of recession, signs of wear and tear from some hostile environment of this occlusion, we do see that the potential for healing is quite positive in cases like so. Another view of the panoramic, and let's look at this cross-sectional view with the CBCT. The remaining bone is quite homogeneous. In other words, I don't see any intra-bony defects. I don't see any difference in the cortical cancellous and so forth. So the first thing we check off is that the quality of bone is quite fair. It looks, quite dense, reasonably dense. Quantity of the bone. We did state from the clinical view there is horizontal and vertical loss in the ridge height and width. Although this is quite adequate to be able to work with, this will form a good foundation for us to be able to place the implant most likely in a one-stage protocol, which is indeed how it ended up. We carefully look at the vessels. We tend to look at the facial bone immediately lateral to the window for vessels and any other pathology. In this case, fortunately, it was quite clear. We also look at the trajectory of the implant that is to be placed in the future, and the opposing teeth that the implant that we place is going to be functioning with. And together with all that, we come up with where and how the implant will be placed together with the sinus graft. If so, where should the window be? So this is a rendition. This wasn't done by us. This was actually presented to us by the local clinic, and it looked quite fascinating, 13.8 millimeters height, which in theory should not necessitate a sinus graft, but this is not as accurate. It was taken at an angle, so it goes to say very careful, astute attention must be given when we are doing 3D analysis. So we will go back into that in just a minute. First thing, let's talk about the flap design. Here we see the actual flap that was raised. I'm going to go through this in quite a bit of detail. The flap has to allow good visualization and access to the site that we're going to be operating. It will have to allow us to place a window exactly where we strategically want, but also it also has to be able to close and contain whatever the material we are intending to put in. Implant for sure, and if it's a sinus graft, we're going to do some lateral graft, what we call contour grafting. Are we going to overgraft the facial aspect to compensate for the loss? And if so, will the flap accommodate that with adequate healing when we close up? So 3 fundamental requirements of any flap and incision is number 1, access, which we see from this slide that access is quite adequate. Containment, can we contain everything? and we will have to do some flap release and mobilize the flap in order to achieve that goal. And thirdly, one of the functions of the flap and incision is, are we going to change the dynamics of the tissue quality? In other words, are we going to redistribute the thickness and the thinness, the keratinized tissue versus a mucosal tissue? Are we going to move things around so that the ending environment of the soft tissue profile is going to be to our liking and to the patient's advantage? So redistribution of tissue. So we'll address all three of these. Here is our initial design. Of course, I had to black out that first molar so that we can simulate this. Typically, the window design should be immediately lateral to the tooth in question. However, when we do a case like this, opening up a window in the lateral surface of a second molar is quite difficult to access. So in fact, the window does not have to be immediately lateral or immediately superior to the tooth in question. It can be slightly more anterior. The limiting factor, of course, is the root of the most, the anterior tooth there, in this case, the second bicuspid. So long as the second bicuspid can accommodate that window without damaging the root, then we should place the window as far anteriorly as possible, because that gives us the angle advantage as we access. The red line here clearly demonstrates the incision design. There are several key components. Do we need to create a vertical drop, vertical release? And the answer is yes. The question is how many? Here we are going to be placing an anterior vertical release, and there's, in my opinion, no need for a posterior one, so we're just going to finish with the circular incision about halfway on the second molar facial surface. And indeed, we were able to carry that out perfectly fine. So that has to give us the access for the window. And then, of course, the next thing that's important is, although the flap looks adequate, we sure need to have a distal component. We need to open it distally relative to the vertical release to be able to gain adequate access. So the dotted pink line indicates what's known as the cutback release incision. The cutback does not have to be superficial. The cutback is actually quite deep and is basically part of the periosteal release. So at the end, when we close up, the incision that's visible on the surface should only be the red lines, should not have to include the pink dotted line, obviously for conservative flap measure. So this is one of the most common and versatile flap designs that we've been using in our field. I've recommended this particular incision design for years that I can remember, and this is a slide that I've created back in the 90s to be able to get this message across. Very typically, when teeth are lost and the ridge resorbs, there's a alteration of the soft tissue profile, and as this pictorial images indicate, there's usually a reduction in the keratinized width. So by having the incision started in the crestal zone, not in the mid-crest, but in the actual palatal aspect of the future implant, it actually helps in many aspects. So Fundamentals of Incision Flap Design says lingualized crestal incision is to be used wherever possible, and then we basically move that tissue facially. So it's a facial pedicle incision graft, and as a result of that, we gain many things. We increase the facial attached gingiva. We also thicken the facial tissue because we're now taking thick, robust palatal tissue that's above the crest and even on the palatal side, and we're mobilizing all the way to the facial aspect. And also we deepen the vestibule, and in doing so, many times we just completely eliminate frenum attachments and all these other things that get in the way of ideal healing and for ideal future function in this area. So coming back to this incision design, you will note that in the upper left corner of this image, we see a V-shaped notch that's somewhat superior to the mucogingival line that's existing, and you don't see any incision beyond that. However, be assured, there is a cutback that, remember the pink dotted line, is actually hiding underneath. At this point, I'm going to bring up another important point. The vertical release anywhere in the mouth starts in 90 degrees. It is a perpendicular incision relative to the gingival margin. So this blue line, which is actually the start of the incision, and the yellow line that indicates what used to be the gingival margin, the free gingival margin, that usually should be 90 degrees, forming a sun ray type of a configuration, whether it's on the distal or on the mesial. That rule should be kept. For many reasons, the geometry allows better blood flow and better closure. And when we talk about the closure, it shouldn't be an afterthought. We want to leave an adequate zone, in this case, somewhat of a rectangular rhomboidal shape where the pink shaded area is. That should be quite firm, attached, has its own blood supply, because that's the only way we can get the flap to close quite readily. So that is a point that we shouldn't forget. So now we have raised the flap, and we were excited to start making the window design. But this slide indicates one very important step that we all tend to overlook. Whether there is going to be a graft on the facial surface or not, I feel that it is quite empirical that we scrape the bone surface for several reasons. Number one, you can see what's indicated here. This is a small end of the Pritchard periosteal elevator. It should have a sharp tip. If not, you should be polishing and sharpening periodically. And this was actually used to scrape the region around the future window, but in general, any bone surface that's exposed. What is picked up on the instrument? That is a lot of soft tissue, part of periosteum, and many times it could be pathological or something that's not going to contribute to future bone growth. Whether you graft this area or not, it is imperative that we get rid of any unwanted soft tissue, because soft tissue that gets incorporated into a graft for guided bone regeneration absolutely is not going to contribute positively. So soft tissue should be eliminated. Bottom line, we don't want anything but bone-forming cells, and there's only two types of cells: bone-related cells, osteoblast, osteoclast, and so forth, and blood-related cells. That's it, nothing else. So scrape everything off, periosteum or otherwise, everything should be scraped off. I emphasize this point because of this. When we look at bone versus periosteum and then all the superficial structures, the submucosa, lamina propria, and ultimately epithelium on the surface, let's zoom into this area where we see bone and periosteum. In diagrammatic, pictorial, presentations, we look at that, and it's almost as if bone and periosteum are two distinct phases, and as soon as you raise a flap, these phases are separated. But in reality, that is not the case, because the bone to periosteum is really a continuum of hard, soft tissue, and then there is no distinct point where there is bone versus periosteum. But this red line indicates where we need to be. In other words, yes, the periosteum does contribute to bone growth, but in this situation, there's no guarantee all of that is in the flap side. Therefore, I want to keep that red zone completely bone. So scraping with a hand instrument, rotary instruments, using chisels and other instruments are quite valid. In these days, we tend to use piezoelectric surgery quite a bit to ensure that that red line represents bone and nothing else. In doing so, we actually create what's known as regional acceleratory phenomena. Harold Frost's early work back in the 70s and 80s have contributed to this field through orthopedics. But in dentistry in the recent years, we have fully accommodated this concept, which is very, very relevant and probably one of the most fundamental facets of guided bone regeneration in the contemporary sense. So Only when we have done all of that to clean off unnecessary or unwanted cells, excited the bone so that the bone is not what I call the lazy bone. I call it the lazy bone syndrome. The bone went through homeostasis, and now by stimulating and scraping, and perhaps even opening up some of the small vessels within the bone, we are now getting this lazy bone to wake up and this call to action. This window design, earlier on, 20 plus years ago, we used to do stamp outline, using a circular rotary instruments. We went through that phase, but this is a technique that I've been using ever since, at least for 10 plus years. And this was publication by Professor Son and his group from Daegu, Korea. It's known as the replaceable bony window. And this is quite an ingenious method to use. We clearly use piezoelectric surgery to achieve this, and the characteristic is that there needs to be a bevel. The bevel cannot be put in all sides, so we typically choose the inferior and the anterior portion to give a bevel. This one is pronounced. It's very uncommon to be able to get a bevel that pronounced, but luckily we were able to do this. We are a couple of days away from Halloween, and during Halloween in the United States, we do a lot of just pumpkin carving, and I've done a few of those with my three boys. The pumpkin carving, we don't want the lid to drop into the jack-o'-lantern, so we actually do it at the bevel. It's exactly the same concept. So the bevel allows us to replace the bone to its original position, and there's a containment. Professor Son and his group are known for boneless. They put concentrated growth factor into the sinus. I tend to put bone and sticky bone into the sinus, as in this diagram. But either way, I still want the bevel to help me orient and fit the window back exactly in the position. Not only is it neat and contains everything, this is an osteogenic. This piece of the bone that is separated from the site for, hopefully not more than an hour or so, is put back in, and it will form new bone by simply healing process, not a regenerative process. In this case, we did place an any ridge implant, any ridge octa, which is actually also known as Blue Diamond. This product is, of course, from Megagen. Any ridge octa has very aggressive threads. It has slight taper. This shows that it has a core of 3.8 millimeters, but the fins or the threads spread out 4.4 millimeters. So this is an excellent implant to be using in this type of situation where we're clearly doing one-stage surgical protocol. It is a 13 millimeter implant, and the later radiographs will show why that is so beneficial. The end result, the implant is placed, the bone is packed in, and then do we need to do some extra grafting on top and so forth? But since we couldn't document this pictorially, let me go through the sequence of how we got to this point from the time we actually opened up the window. So this is schematically what we are doing. The flap is raised to expose the bony site. And note that in the bottom of the screen, we are looking at a position of incision slightly to the lingual, slightly to the palatal, so that a simultaneous implant placement could be done. But also, I insist on doing this palatal approach because it really makes the logistics easier. We do not need a second retractor on the lingual side, which all it does is really mutilates the tissue. There's nothing good that comes out of the so-called mid-crestal incision. I really, honestly, personally get quite irritated because people talk about the mid-crestal incision as if there's nothing else available. But no, we can do palatal approach. So here is a window that is open. This picture, these graphics were developed back in the late 90s by myself and my previous artist. So this was the day that we didn't use piezoelectric surgery. So pardon me, and then there's slight bevel, but not much. So this is an old diagram. Here we use a number of different types of curettes, sinus curettes, to be able to lift and raise the synthetic membrane. This image is put there to say what is unnecessary. there is absolutely no need to raise the Snyderia membrane from the superior aspect. Absolutely no need to do that. All we need to do is go inferior and then go across the ridge. And what is important is to go through the ascending part to the medial side, approximately the same level as the window. So in this diagram, we've got to go another 3, 4, 5 millimeters. The reason for that is obvious, because earlier on, myself included, many people have made this type of mistake, not knowing the anatomy fully, not reaching out the instrument fully to the other side. And when we just think that we've raised adequately in place bone, this could be a disastrous effect, because you're going to have a convoluted Snyderia membrane that's inferior and medial to the graft, which will be a disastrous result. So we learn from our mistakes, and I'm going to admit fully that we've done things like that earlier on in the development of the sinus graft techniques, and today we say this is the ideal shape that we would like, and then of course implant can be placed many times simultaneously, and then of course the window can be replaced exactly where it comes out. So when you do a one-stage surgery, and if the remaining bone is sound enough to be able to pull off a one-stage surgical protocol, I insist on putting a healing abutment. The healing abutment not only allows us to do one-stage surgical protocol, but the healing abutment allows adequate healing with movement of the palatal tissue towards the facial to fully utilize the thickness of the tissue, the character, in other words, the keratinized tissue that's going to migrate to the facial and to deepen the vestibule, and all the good things we talked about. Many questions about the healing abutment. Here, this is a label that says 505. No, this is not Levi's jeans. This is Megagen's healing abutment. The healing abutment has two important numbers. One is the width, one is the height. So let's go over that very, very quickly. This is a universal tip for whichever implant system that one might use, and is quite valid. Most implant systems companies manufacture healing abutments with about 4 millimeter width, 5 millimeter width, and 6 millimeter. There are some variations, but that's generally the case. In my dictionary, the 4 millimeter healing abutment is ideal for a bicuspid or an anterior zone. A 5 millimeter is typically for a molar area. Quite simple. I use 4s and 5s. There are times I break that rule, and I may be using a 5 millimeter width on a bicuspid or even an anterior zone if my objective is to push the palatal tissue to the facial by some degree more, because the width of the healing abutment determines how much tissue mobilization we create. The height is very, very simple. The height has to accommodate the soft tissue thickness, so that tissue simply does not cover the healing abutment. So in this case, it was a 505, which meant width was 5 millimeter and height was 5 millimeter. Now, many times with the conical connection family of implants, we tend to place the implant shoulder submerged relative to the crest of the bone. So it's very common to submerge by about 1 millimeter, sometimes even 2, sometimes even more than that. In this case, it was actually submerged roughly 1.5 millimeter, like this diagram shows. So when you are submerged by 1.5, and if the soft tissue that remaining is roughly 3, with a 5 millimeter healing abutment, you are lucky to be quite flush. If that happens to be the case where tissue tends to crawl above the healing abutment, then I would choose a 1 millimeter taller healing abutment, maybe a 6. Of course, the upper limit, you can't keep going to 7, 8 millimeter height. If the height of the healing abutment is going to be interfered in the occlusal function, in other words, if the patient can chew on it, then it will possibly unstabilize the implant. Therefore, there's that upper limit. But that being the case, I want to put in as tall of a healing abutment that will allow easier closure and flap management. Another thing that we need to consider when we place healing abutments, in other words, when we perform a one-stage surgical protocol, is that the gap between the healing abutment and the crestal bone, the profile has to be created ideally. Now, I'm going to give you a very simple answer. I tend to do a lot of this with free hand before the healing abutment goes on. Pick up a small diamond round burr, copious irrigation with a high-speed air rotor, and just free hand carve, create that gap. But you know, all manufacturers, including Megagen here, produces what's known as a bone profiler kit. What this involves, the gold structure in this diagram, is a guide that is placed into the implant. As you can see in this cross-sectional view, the threads allow very secure placement. And then the profiling drill, which is a rotary drill run off the same contra-angle implant handpiece, is snugly fitted over, and the parallelness, the chimney shape, will allow the drill to rotate only in one plane, and therefore allow precise cutting using this roughly angled profile drill. So that is how we create the profile. And basically, the simple rule here is how much profiling do we need to do? The gap has to be there. It is a mistake for the healing abutment to touch the bone. Not only will that allow the healing abutment to not engage fully, but by having the healing abutment touch the bone, we are forcing the bone to say, hey, we want you to remodel this and create a normal sulcus, normal emergence profile, the bone to soft tissue to titanium interface. And when body has to do it on its own, there's a highly likelihood that we may not have very even shape. Therefore, we might have some bone defects, haphazard bone architecture that could be created because of the remodeling process. The body is desperately trying to create this. So, give body a break. Periosteum needs space. And the periosteum is at least a millimeter or so thick, at least. So give it a break. Periosteum has to form immediately for the bone to survive. So my rule is give it about a millimeter thickness of space between the healing abutment and the crestal bone, the remaining crestal bone, or more. I wouldn't create 3 or 4, but I would create somewhere between a millimeter and 2 so that the periosteum has easy time getting adapted. What we see here is the replaceable bone window has been indeed placed back into its position. We have grafted the area with small amount of bone above the window, and then we have placed at least a couple of layers of concentrated growth factor directly over the window, but you can clearly see that it tends to be wrapping around the healing abutment. What is that? That is a concept where we want to introduce this concentrated growth factor where it is needed the most, and that is the junction where the crestal edge of the flap and incision goes. And this, again, our good friend, colleague, Professor Son, has introduced this as the Poncho technique. In fact, we developed this Poncho technique while he was in Mexico with us doing some initial training programs some 10 years ago. So it's known as the Poncho technique, inspired by the Mexican Poncho. So there we have it. And this is a very neat technique that allows the one-stage surgical protocol to become even more predictable. Not that it isn't. I advocate one-stage protocol wherever feasible, and I tend to do that approximately 82.3% in my own office, according to the last data that we have analyzed. About 20% of my implants are submerged or buried, but 80% of my implants, vast majority, are either getting healing abutments or provisional restoration of some sort, including when we do full arch cases, the all-on-4 conversion usually is a one-stage surgical protocol. If somebody says, isn't that risky? I'd rather stay safe and do a submerged. I have a very quick and simple answer. There is absolutely no difference in the literature between one stage and two stage. And is this a local or a more recent phenomena? The answer is absolutely not. The Straumann group and the Brennemark group has long history. Their research, the original Bonafit implants and so forth, going back 40, 50 years, going back to the 60s and 70s, have always been a one-stage surgical protocol in the Straumann camp. For us to say this is a new thing is completely untrue. For more than 50 years, one-stage surgical protocol has been reliable. The key is stable implant, very precise soft tissue manipulation, and the ease of healing. Okay, I was distracted there while the screen was showing. This is our landmark paper, Sticky Bone in Implant Dentistry, and there is, of course, Professor Son and myself. Every time we see each other, there's somehow beer involved. I don't know why. So this is an example of how one of my own cases from private practice where a provisional restoration is being placed in an immediate site. And because it's an anterior site, of course, we want to have the patient leave with a non-occluding implant restoration, non-occluding implant restoration, N-O-I-R. That's a term that I've came up with and I like very much, NOIR, N-O-I-R. So non-occluding implant restoration, but the key is we tend to dress it up with a Poncho to enhance the healing, as in this case. So back to our case from Tijuana, Mexico. Now we're putting everything back together. Just like a good jigsaw puzzle, the flap should come together, and we do want to utilize that somewhat of a not too tall, not too short healing abutment with a poncho wrapped around it to be able to get a nice closure. And this is quite reasonable. This is quite acceptable. But notice there is this tendency, unless we put a very tall healing abutment, for the crestal soft tissue to rise above the healing abutment. And this is a very common thing that we tend to get very, very frustrated. So today I will show you a very, very easy trick. I call it the turtleneck suture principles. And I'll show you how we can turn this situation of frustration into the image on the right, where we can clearly see the healing abutment and approximately 1 millimeter of it is rising above the flat margin. And you can see how that will decrease the dead zone, decrease the amount of keratinized tissue that might get wasted because of lack of blood supply. And of course, that will reduce the keratinized zone, reduce the zone of keratinization, reduce the facial tissue thickness, and of course, the vestibule. So here we go. This is the explanation for what I call the turtleneck principle. This is my son Stanley. He doesn't like me doing this, but he doesn't have a choice. So here is a young kid that we want to send out to the wild, and of course we want the kid to be protected by a nice turtleneck that protects his neck and all the coverings. We sure don't want him to walk around like that on the left. He can't see, he can't figure things out. So this is Stanley with the turtleneck in the proper place. So let's do that for our patients. So here a diagrammatic representation of the two sides of the tissue on a typical healing abutment. We want to line them up. One side is going to be non-mobile, in this case the palatal, and one side represents the facial or the mobile tissue that needs to be tacked down and basically stabilized. So the first thing you do is draw an imaginary line immediately adjacent to the mesial and the distal line angles of the healing abutment. If the suture goes outside that line, what will tend to happen is as the suture is pulled and the tissue is advanced, chances are the tissue will rise and climb above the healing abutment. That's typically the case. So, simple rule. Draw the imaginary line and start the bites on the palatal side and the facial side relatively close to the edge, no more than say a millimeter, millimeter and a half. Not a big bite, a small bite. In the palatal, it doesn't matter, but on the facial movable tissue, it's got to be a relatively small bite, but it has to be within the confines of the diameter of the healing abutment. So when we put that together, as we tighten, the two long aspects of the suture will get tucked under the convexity of the healing abutment, and in doing so, tissue will tightly wrap around the healing abutment. This is exactly the same principle that we use in typical periodontal surgery. When we raise a flap, a full thickness flap for any periodontal surgery, typical flap and osseous, crown lengthening, and the likes, then we want small bite, very tight, and the sutures get into the embrasure areas. And of course, natural teeth are contact, and embrasures are much more emphasized, so it tends to be a little bit easy. But when we work with a very simple cylindrical structure with not a whole lot of flare and embrasure, this challenge becomes real. So there is the first one. And on the second one, we do virtually the same. So by doing this, we constrict the tissue to come across and wrap around the most narrowest portion, or the most apical inferior portion of the healing abutment. And that's how we end up with the turtleneck suture that I am advocating. You can do that for multiple implants, you can do for a single, and of course, I'm assuming that flat release and flat mobility does allow us to do that. So now that you see this, I hope you will see this with different light and be able to say, I can do that. Now, the key thing also is the choice of suture material. I am not a fan of non-resorbable sutures for a number of reasons, but my go-to is a chromic gut suture. I was trained with that. I was mentored with that. My best mentor, Dr. Thomas Hahn from Los Angeles, who had taught me everything I know in periodontics, he uses this type of material. The key thing is you got to choose good chromic gut. There's a huge variation in manufacturers and the quality of the material, so you've got to choose a reputable brand that makes good quality chromic gut, and they are much more manageable, easier to work with, and the beauty is they will dissolve somewhere between 5 to 10 days. So as soon as the tissue stabilizes and the microcirculation is re-established in that time, we are home free. And you don't have to come and hurt the patient pulling out these sutures, wasting your time and effort and all that cringe in your face trying to get some of these sutures out. You don't have to do any of that. So this is it. This is a turtleneck suture that was employed in this area. And of course, the vertical release, you have a lot of versatility there. You can do individual loops, and you can be very creative. And in this case, that vertical release does come together. I wish I would have placed one more suture right at the most, coronal portion of the gingival margin. But hey, I think that's quite acceptable. The vestibule is indeed deeper. We see a lot more keratinized zone, which we hope that will be to the patient's advantage. And here is the proof in the pudding. We see the cross section of the implant, and indeed this is a 13 millimeter implant, and the assessment was incorrect. What was remaining in the residual bone height was most likely 7-8 millimeters, because we did indeed raise quite a bit. Now, if you look carefully, the window is not very visible, but somewhere there we should be able to pick up the cross section of the window. So the window is hidden, which means it's well integrated, not very well isolated. Very, very good picture. And this image shows us that the lift is gradual, not very drastic, and the bone was indeed packed very well into the sinus membrane, underneath the sinus membrane, and therefore we can expect uneventful healing. We can see that compared to the contralateral side, where the Schneiderian membrane is somewhat enlarged or swollen because of a deep or accentuated pneumatization. And this side that we have created, we hope that will not be the case, because now the floor of the sinus, the new floor, is relatively flat. By the time the bone remodels and matures, we expect it to be not so convoluted and relatively flat. This is a CBCT taken in centric, and I really insist on that. There's no reason to use bite forks when we take CBCT, because this just gives us much more rich information. This literally shows us where the future implant will be, and if you can draw a picture of a restoration there, we know that that's going to be a very functional axial loaded implant with sound bone on facial, on the lingual, and so on. The long axis is as good as it can be. So there it is, our team that has done this case beautifully. So we are very proud of the team, and an excellent job by Dr. Kayali. So I hope you enjoyed this video. We do upload quite a bit. Some of the cases are only shared to our participants. Some are to broader audiences. This one I've decided to share to the broad audience because of lots of learning points. So I hope you like us, subscribe, and here's a scan QR code to my website. And this is our proud group. In this October 2024 program, I believe we had 8 or 9 doctors from all over the U.S., East Coast, Michigan, Northern California, Texas. Who did I miss? I mean, we had a number of clinicians from all over really enjoyed. Oh, from Beverly Hills, from Virginia, and we had amazing time. The crew there in Navy are the instructors and staff, support staff. Excellent job. So I'm very proud of this work. So this is Implant Accelerator, and this has been Jen Kim. Thank you for watching this, and I hope we can meet you in Tijuana in the future programs. Thank you very much.